So we've talked a lot about BTK inhibitor, BCL2 small molecule inhibitor. There is another target in the B-cell receptor signaling pathway, which is PI3 kinase. There was an ASH abstract this year, 2019, presented with a combination of umbralisib plus ublituximab plus venetoclax. And I know you've been participating in that trial. Maybe you can give us your thoughts on that combination and what your experience has been.
The first PI3 kinase delta inhibitor was the adalimumab, which was FDA approved several years ago in combination with rituximab, which has shown benefit in relapsed refractory CLL when comparing to rituximab alone. There's another PI3 kinase delta inhibitor, which is a umbralisib, that's been shown in the dual trial comparing to ofatumumab, showing progression-free survival benefit. Both of those PI3 kinase delta inhibitors actually are considered first generation. The main problem with that is that there's some concern about the potential toxicity, mainly regarding the immune-mediated hepatitis, liver toxicity, and the immune-mediated colitis, severe diarrhea, as well as the infection risk. The umbralisib is actually the next generation PI3 kinase inhibitor that's also focusing on delta isoform. There seemed to be a much better toxicity profile with this new PI3 kinase inhibitor in that the hepatic toxicity as well as the diarrhea, especially the grade 3 or more toxicity, are pretty rare. There are some grade 1 and 2 toxicities which are easy to tolerate. So in this study, this is a study designed for patients with relapsed refractory CLL, combining umbralisib, PI3 kinase inhibitor, plus ublituximab, which is a novel anti-CD20 monoclonal antibody, plus venetoclax. So you have an initial phase of debulking with just what we call U2 combination for the first 3 months, and then adding the venetoclax for the 12 months. So the entire treatment is actually for 12 months. And then at the end, if you have an MRD undetectable state, then all treatment will be stopped. So the first report was presented at this year's ASH 2019, which showing very encouraging results. Most of the patients were able to actually achieve an MRD negative state at the end of 12-month treatment and came off treatment. And all of the patients had response, so the overall response rate is 100%.
And tolerability?
Tolerability is actually fairly good, so most patients were able to tolerate very well. There was only one patient were off treatment because of the grade 3 or 4 diarrhea.
Carolyn, I wonder if you have a lot of experience with PI3 kinase inhibitors and where they may be useful in our treatment algorithms?
Yeah, so I mean, I think that it's exciting to hear of newer agents being introduced that have an improved toxicity profile, because I think many of us had experience with idelalisib, the first generation PI3 kinase inhibitor, which really had very significant toxicity in a lot of patients. The few patients who didn't have toxicity problems actually had excellent responses, and I think unfortunately they just didn't, we didn't know how to use the drug properly. You could have a lot of treatment holidays even in the patients with toxicities, and this was in the era before other agents were available, so the patients would want to restart after their side effects resolved, and they could restart, and they kept having good responses. You didn't see a lot of sort of resistance developing for stopping the agent. I wonder if this is an agent that really does need to have time-limited therapy, because continuing the drug is likely to be associated with just too much toxicity. But currently, without clinical trials, most centers still have access to either duvelisib or idelalisib plus rituximab, and we're mostly just using it as a bridge to transplant in those patients who failed BTK inhibitor and venetoclax. Dr. Mato at this ASH 2019 presented some data from subsets of patients treated in that way, and it looked not particularly promising with quite a short median duration of response, but you don't need a long duration of response to bridge to transplant. I think that's really one of the few situations that we're using the agent currently.
Carolyn brought up a very important point when using adalimumab. So in managing toxicities, sometimes people are very hesitant in interrupting doses or reducing doses. We actually done a very large retrospective analysis of pooling several large clinical trials using adalimumab, and looking at patients who actually had dose interruption or dose reduction comparing to those patients who did not. Interestingly, patients who did have dose reduction or interruption actually had better overall survival comparing to those patients who did not. So that's really a hint that if you're able to manage patients' toxicity appropriately according to the guidelines, then those patients can actually do pretty well.
I guess we should mention the ASCEND study. I don't know if you're going to, which was a comparison with acalabrutinib with physician's choice, and the physician's choice could either be umbralisib rituximab or bendamustine rituximab, and that study showed that met its endpoint with progression-free survival for acalabrutinib being better than the other arms. And so I guess while umbralisib still has a place in certain patients, I think there's now evidence that acalabrutinib is a better choice.
The only criticism to that trial, though, was that there was a crossover, and because umbralisib has such a significant toxicity profile, if your patient had any side effect, you knew they would be allowed to cross over to the acalabrutinib. It was there was a clear incentive to not maximize the use of the umbralisib. We participated in the trial, and I know that directly, and so I think that it's a bit unfortunate. I don't think that umbralisib and rituximab, even if used really well, could have beaten the acalabrutinib, which is a very tolerable and effective therapy. But I do think that the study, the outcome is influenced by that.
You think the outcome is potentially skewed by the toxicity and
By
the
the
short duration of treatment for
and
the
the
comparator arm?
Well, the physician and patient likelihood of discontinuing therapy on the idella arm because you were allowed to then cross over.
It is notable that most of the patients on the comparator arm, on the standard arm, did get PI3 kinase inhibitor-based therapy. So for me, I view that trial somewhat as a targeted therapy versus targeted therapy comparison. But as you say, it is a positive trial and clearly shows improved progression-free survival, at least, favoring BTK inhibitor-based therapy and the acalabrutinib.